do today is just put a little bit of information together on where we are now with the pandemic, the sort of problems that you might be experiencing, and some simple self-help strategies, where we're going to be going next, and really what I've been living for the last few weeks, and certainly the last couple of weeks in particular. Where we go next is completely taken over my life, and we've had some really big reports to put in. A very big one for my own association that I'm president of. I finished at 2 o'clock this morning, and I've been up to 1:30 at least for the last week or two trying to do it. And we've also been working with the government on guidelines as well. So there's quite a lot of stuff to update you on. Where are we in Leicester? Well, this is the paediatric intensive care unit, where thankfully we have very little work to do from a coronavirus perspective. In Leicester, we've actually been relatively lucky. We've had quite a lot less coronavirus than a lot of my friends around the country have had a very hard time, and from relatives living abroad in Italy, for example, have had a much harder time than we have. We got up to about 220, 225 infected coronavirus patients on the wards in Leicester a few weeks ago, and we've gradually been coming down. So down to about 150 on the wards at the moment, and relatively small numbers in ITU. So we've had masses of capacity. We've never had this much capacity in ITU. We've never had this much capacity in the wards. So I think that, you know, if anyone does get ill, that there's a lot of people to look after you, and a lot of capacity in the hospitals to look after you as well. However, we have essentially stopped normal practice. So we're not undertaking any surgery at the moment, except for cancer surgery and for urgent surgery. And we're not undertaking any outpatient clinics either, face-to-face, except for emergency work, nosebleeds and maybe urgent cancers and so on. Because we really didn't understand the virus and we didn't know what was going to happen, the government quite rightly put a stop to all of it to try and reduce spread. And inevitably, as a consequence of that, we've stopped all balance testing nationally. Has been stopped. That's a government guideline at the moment. And almost all hearing loss has been stopped. There's a couple of examples where we do insist on hearing loss, and that includes if you have a serious illness and need gentamicin, or you're having chemotherapy, or you have a sudden loss of hearing, a sudden sensory neural loss. That's still a medical emergency, and we're still seeing that. Now, we can't leave you because people still get dizzy. Interestingly, in ENT, our referrals have gone down enormously outside of balance, and we think probably because everyone's self-isolating, they're not catching all of the other bugs that they would have caught. So we're not seeing things like serious sinus infections, serious ear infections, serious throat infections anywhere near as often as we used to. And I suspect, I can't say for sure, but I suspect when lockdown lifts, there'll be a lot less infection in the community. Because I've had people asking me, are we all going to get terrible infections when we start meeting people again when lockdown lifts? I actually think the opposite will be the case, because the viruses and bacteria circulating in the community will have been diluted out as well. So actually, I think we're going to go back to a healthier world, which is something nice to think about. Now, what we are doing instead is we are doing what are called virtual consultations. So what these are telephone consultations generally in the NHS. And we're going through every single set of notes. I've read the notes of every single patient on my waiting list for clinics. And when an appointment time comes up, I'll look at all the notes. If it's something that clearly needs to be seen face-to-face, which is almost nothing at the moment, I arrange to see people face-to-face. The majority of people are getting a telephone call, and some people where there is no great need to have a call at the moment will get deferred by a few months, and then we'll see you face-to-face later on. The telephone consultations are actually pretty useful because we can initiate a number of treatments with them. We can book scans. Urgent scans are getting done quickly. Routine scans are generally being deferred. And we're very sensitive if you're in a high risk group. We'll try not to bring you into hospital because hospitals aren't the healthiest places to be at the moment. We can book balance tests, but we're not doing them at the moment. Again, that's a national guideline. All balance tests have been cancelled or postponed, should I say, for the time being. Now, on a private basis, very similar rules apply. We're still doing virtual, sorry, all the banging. We're still doing virtual telephone consultations. We're doing a lot of Zoom consultations. We can also do Skype consultations if necessary. And if you want a private appointment, you can just get in touch through my secretary, just Google that online. We're not testing at the moment, as in keeping with national guidelines, because we're only going to do private work in step with what is being done in the NHS and nationally. We're not going to go out on our own on that, on a limb. But we are, for what we're doing is patients who I'm seeing virtually, privately, we're keeping a note of, we're building up a sort of a file on this, and then everyone will go in as required when we reopen, which I'll come to. But actually, it is amazing what you can do on the phone. Not only can I do lots of treatments, which I'll show you, I can send you prescriptions in the post, I mean, as I can, of course, in the NHS. We can do virtual examinations, and we're doing some research on this as well, but it's been a really interesting development, and I hope going forward we'll be able to do more virtual consultations to save people, particularly people who live quite a long way away, coming in. I mean, over the years I've done a lot of virtual consultations with patients all over the world, I mean really all over the world, and they've been very, very successful, I think. The feedback's been really, really good. So maybe we're moving into a slightly different world. Okay, let's see if I can get, there we are. So what I want to do, I just want to take you through a few of the commoner conditions, and you will all have, I suspect, some of these. Now, BPPV, benign positional paroxysmal vertigo, is that condition where you get dizziness when you look up, you lie down in bed, you roll over, you put the washing out, you put a cup up on the top shelf. Short spins. I suspect we're going to find it's much more common during this period because we're less active is one of the things. So historically, I see a lot more people with BPPV after that say they've had spine operations or hip replacements where they're lying flat, when they've been on a cruise and been laying in the deck chair. That's a really common time to get it. But now, of course, we're self-isolating, we're at home and much less active. So the crystals in the canal in the ear just settle like sludge at the bottom of the canal, and you get more BPPV. Now, a second very interesting thing, and I talked about this when I gave you a talk a few months ago, or before Christmas, I think, wasn't it? Is that we know that very low vitamin D levels are associated with BPPV as well. And of course, now we're all self-isolating, perhaps we're getting less sun. Maybe some of us are getting more sun. I think I'm getting more sun actually at the moment because I'm not working in the evenings. But those of us who are unable to get outside are more likely to get vitamin D. Now, one of the other things is, it's not just a matter of BPPV presenting with positional dizziness, lying down in bed, rolling over, looking up. But you need to be clear that if you're getting episodes of disequilibrium and feeling rubbish, that, but John, if you've got, can you hear me, John? I saw a thumbs up there. Are you okay? Yeah, you can hear me, okay. But it causes disequilibrium as well. So you can feel just sick when you're moving around, which is actually not what it says in the textbooks. And look, here's a video. Oh, yes, here's a video of my poor wife last week. Now you'll just see a little bit of downbeat nystagmus here. Her eyes are jerking down. That wasn't a terribly impressed there. Can you see her eyes flicking? So that's my wife last week with posterior canal BPPV. And the week before, she had absolutely dramatic lateral canal BPPV. So her eyes were jerking, horizontal nystagmus like this. Very, very sick. Not just unable to lie down, but nauseous, dizzy, sick and distressed all day. Now, my good wife has the advantage that I can treat her. And that's what I did. So I gave her some Epley manoeuvres and barbecue manoeuvres. But what sort of self-help might I be able to offer you on that? Well, there are actually quite a few things that we can possibly do. So the first thing is, think about vitamin D. If you're not able to get out and get lots of sunshine and you're really self-isolating, I'd strongly suggest you take vitamin D tablets anyway. Generally 1,000 units a day, they cost a few pence from the chemist. If you're really low, you can start with 4,000 units a day. That's what we have at home. Take those once a day, maybe for a month. If you have other medical problems, kidney problems, liver problems, and so on, you may need to speak to your GP before you take that, but you can buy them over the counter. Easy as it is for me to say, I'd like you to take as much exercise outside as you can safely do. There are lots of benefits to this. I'd like you to, if you've got, for the BPPV perspective, add some extra pillows if you get attacks, so use 2 or 3 pillows rather than 1 pillow. Try not to lie flat, so no lounging on your deck chair or lounging on a settee, watching whatever the programs are that the people are watching now. And then we can actually undertake hall pikes and Epley manoeuvres on the phone. So I do some hall pikes with just on the phone itself, without undertaking quite a few in the last couple of weeks, just on the phone. Even better is to get your smartphone. And if we do a video consultation with a smartphone, then if you hold the phone up to your eyes and you lie back, I can't see myself on the screen, so I don't know what I'm doing. But if you lie back and then lie flat on the bed, roll to one side looking at the phone for me, and then roll to the other side looking at the phone for me, I can actually see your eye movements. So for my Rupal's looking fairly distressed at that. So if you have what my wife had, I'll see horizontal eye movements. And if you have posterior canal BPPV, you get torsional. In fact, I had a lovely lady I did this with 2 weeks ago who had really terrible posterior canal BPPV. So her eyes were spinning like this. I lay her back on the bed, and then it turned into a horizontal. So I'd given my poor lady severe horizontal because that's quite easy to do an Epley manoeuvre. And so we did an Epley manoeuvre, followed by barbecue manoeuvres, followed by Epley. And I think I got it better. So, you know, you can actually do this on the phone, and we can also do Brandt Daroff exercises as well. I'm going the wrong way here. There we are. So these are the crystals. Here's the utricle where the crystals arise from. This is deep inside your ear. And if you're sedentary, these little crystals, 6 millionths of a meter across, break off, and then like a sludge, they stop with gravity at the bottom of the canal here. Then you roll over and they move around and make you spin. And what we want to do is Epley or barbecue manoeuvres to get it back into the utricle and get you sat up in there. And this is the Epley manoeuvre. And this is Claire, who some of you might know from the London Ray Clinic. She's an audiologist. And this is one of our old reception staff a number of years ago. So with the Epley manoeuvre, this is what I'd want you to do with your phone, is you'd lie down here on the bed, maybe with your other half. You don't need to have your head over the edge of the bed because we can protect it. You might not be able to. But if you're on your bed and your mattress, and if you just tilt your head back a little bit into the bed, with it 45 degrees one way, so half the way over, and then you've got your phone looking at your eyes. Oops. And then you can turn the head round to the left with the eyes this way. And then if we're going to proceed, if it's right-sided crystals, I'll then ask you to roll onto your left shoulder, looking down towards the ground. And you might be very dizzy there, but just make sure you keep your head down. So it's really important you don't lift your head up as you come round. And then we roll up, and you probably won't be smiling like Claire is at the moment. You'll feel pretty rotten. But it's a really good way of treating it. We can do that on the phone if we need to. If you can't get access to a consultation, then if it is BPPV, you can't get access to consultation, and you don't know which ear it is, the Brandt Daroff exercises are okay. If it's really severe BPPV, they'll make you feel really sick, and I wouldn't do it. But if you've got a mild recurrence, they're reasonable to do. So again, what I'd ask you to do is turn your head 45 degrees to the left, then lie on your right side. So we go from there to there. Wait till you stop being dizzy. Then sit up, and then look 45 degrees to the right, and then bang, go down and lie on the left side, looking up into a 6-foot person's eyes, that sort of angle. And then you do it 3 times each way, 3 to 5 times each way, 2 to 3 times a day for about 2 weeks. And if it makes you quite dizzy as you start doing it, you've got the right treatment. And then hopefully over the weeks it will reduce. So I think that BPPV we may be finding there's more of it in the community. Because we're not having much access to people at the moment, we don't know, but that's how I'd suggest you treat it. I'm going to run through the other conditions fairly quickly. Vestibulopathy, that's weakness of inner ear, balance function causing unsteadiness, may well be better or worse. It may feel better because you're not out being so active at the moment, but actually it's probably going to be getting worse at the moment because your balance system is going to be rusting up because you're not stressing it and turning it. And a lot of people, I think, feel better at the moment because they're isolating, but I fear when people start going out into the world again, things may get a lot worse. A little bit of good news, perhaps for other people, is I think there's going to be less community-acquired viruses out there at the moment. So I think the incidence of vestibular neuronitis is going to go down in the coming weeks and months. It'll return to normal eventually. Maybe there'll be a slightly lower number of people getting acute dizziness. The key here, as always, is keep yourself as mobile as you can. Take your half-hour or hour exercise outside as safely as you can, if you can. Get into the sun. You need that not just to stop your balance system. This is the vestibular ocular reflex. I'm doing VRT, vestibular physiotherapy. Well, it's making me a bit woozy actually, looking at the screen. But that's vestibular physiotherapy. You need to be doing that. But going out keeps you fit. It's good for your mental health. And most importantly, of course, it strengthens your muscles as well. Because if you take to your couch, take to your house, your muscles are going to atrophy, they're going to shrink, they become weaker, and that will worsen your balance as well. And those of you who have already started vestibular physiotherapy, really encourage you to carry that on. If you haven't, or you need updates, we can do vestibular physiotherapy on the NSH, I'm not sure what that is, on the NHS and privately. I was up to 2 o'clock this morning before I wrote this, sorry, on the NHS and privately. That's actually really good. In fact, what we're also doing, just for the very far future, is I'm working with IBM and a very famous professor of computing who founded the semantic web, one of the founders of Google and so on. You may have heard of Tim Berners-Lee, who founded the World Wide Web. He wrote the original paper with him. So we're working together as a team to develop artificial intelligence-led diagnostics and also probably chatbot-led physiotherapy on screen. So we may be getting virtual physiotherapists for you. Sorry, Michaela, I'm not going to put you out of a job, but that may be something for the far future. One of the things we're really interested in at the moment is triple PD, not BPPV, triple PD, persistent postural perceptual dizziness. And again, I spoke briefly to you about this before Christmas. We've been very fortunate at the University of Leicester, where I have a fantastic new colleague, where we've just been awarded, well, he's done all the work, he's been awarded a $2 million grant to investigate vestibular migraine and triple PD. Now, it's the biggest grant I know for balance in the UK for many years. It's very, very exciting. And so we'll be getting in touch with people over the next year or two. And so don't be surprised at all if you get a letter from me or my team asking you to come and help us, because this is an area which has been dismissed in the past. You know, people have been called all sorts of, given all sorts of sort of diagnoses and non-diagnoses, when this is a real thing that's going on. And it's a structural thing in the brain, where the brain isn't working, its brain cells aren't talking to each other properly. Now, one of the concerns is that this is going to get much more common in this period of lockdown. Triple PD is different to vestibulopathy. It used to have lots of names: chronic subjective vertigo, visual vertigo, phobic postural dizziness, space, psychogenic gait disorder. There's a whole range of things it used to be called. So we've tried to pull it all under one banner. And it's really a non-spinning vertigo. People feel they're on a moving platform, they're on a boat, they feel unsteady, that they might fall, sometimes feel lightheaded, feel dissociated. In other words, not in this world, not with the planet. When there's motion around you, when you're in a supermarket, when I'm doing this, when there's motion on the screen, when you watch the TV, when you walk through patterns. Or one of my patients yesterday said, when the grandchildren are running around her, when the dog's running around her, that motion is enough to induce dizziness. But when you're lying flat in bed, paradoxically, or in contrast, should I say, the symptoms are much less. You have this visual hypersensitivity. And it's all because we know usually it's triggered by a problem here in the inner ear balance labyrinth. It might be BPPV, it might be a vestibulopathy. But all these complex connections in the brain, right up to here, the frontal lobes, the front of your brain, which is the bit that makes you human. In here, there are processing problems with balance. And it's where many people who get chronic balance disorder have the problem. And we're really excited about the amount of work that's going on here, because we've got lots and lots of ideas about why this is happening, how we might get it better. And this investment we've had in Leicester is incredibly exciting as part of an international group of specialists who are trying to make progress in this problem. And we treat this with explanation. This is what it is, and it's good to know that there is a problem going on, and that, you know, and I've said it to, I'm looking down the screen here because I've just got little, I can move down everyone here. I'm just seeing you all and recognizing faces, and I know that several of you said exactly the same thing to me when I gave the diagnosis. And the commonest thing that my patients say to me is, "Thank God I'm not going mad." Yeah, you're not. You've got something real going on here. I know that, you know that. I and no one fully understand what's going on in your brain, in these connections in the frontal part of the brain. But this is what we're working on now. And sometimes treatment leads our understanding. In other words, by serendipity or chance, we've discovered things that can help before we fully understand why they're helping. Now, what my concern is, and I've spoken to one or two colleagues about this, what my concern is now, and as lockdown begins to be lifted, this may become a much bigger problem. Because when we're isolated in our home, there are, of course, mental health issues and psychological issues that affect everyone, all of us, because we're all human, you know, we're not robots. And I've said that to many of you as well, I know. But when we start going outside, there's a great fear for many people leaving the house, becoming infected. And it's a rational fear. And it may mean that a lot of these symptoms get worse. So understanding what's going on is important, but also vestibular physiotherapy can reduce symptoms in very many people, and that's a straightforward thing to do. Medication can be helpful. And here I'm talking about venlafaxine is the poster child medicine. It's an antidepressant, or the SSRI medications, sertraline, citalopram, and some of you will probably be on them or have tried them over the years. But we're not using them as antidepressants or anti-anxiety medicines. We're using them, we think, to work on the serotonin, which is one of the chemicals in the brain, in the vestibular nuclei, and to try and sedate that bit of balance function. We don't know for sure why it works, but we do know from our research that it does work in many people. So that's something we like people to be on the medicine for about a year, start at very low doses. And sometimes we have to flip between one and another. And then psychological therapies, such as cognitive behavioral therapies, and Michaela's sort of taking a great interest in this, and to try and reduce hypervigilance, because hypervigilance is a word I've used with you many times, and it's where the brain becomes super sensitive to one area. It might be tinnitus, it might be dizziness, it might be many other things. And that thing starts really frustrating you. And of course, if you've got migraine, your brain is already hypervigilant. And so you're in a doubly difficult position. Meniere's disease is Meniere's disease. It's difficult to manage. It's been really frustrating not being able to see my patients, and I'm sorry I've not been able to. But as I'll say in a moment, we are allowed to do intratympanic injections. And, you know, we can discuss on the phone the symptoms, we can arrange scans, we can discuss lifestyle and dietary modifications, and simple medicines like beta-histine, which, you know, those of you who have met me will know there's a question mark over its effectiveness, but all of these things can be done. But ultimately, for investigations, we'll need to meet to go through that. And then finally, vestibular migraine. It's really common. about 10–15% of the population have migraine, and about 10% of migraine attacks present with dizziness. You may not have a headache with it. Usually you've got a history of migraine or a family history of migraine, or you might get visual migraine, zigzag lines, flashing lights and so on. But it's really common. And those with migraine are much, much commoner in the balance clinic. And 40% of my balance patients have migraine as well. And I don't mind repeating what I've often said. For those of you who have migraine, I won't do a show of hands, but I suspect a good half of you will have migraine. I've always said that migraineurs are advanced human beings. And of course, I get it, and Michaela will be happy to tell you she gets it as well. So we're very understanding of this. And I wonder myself whether migraine actually produces an evolutionary advantage. So our caveman ancestors many millennia ago, those who had migraine, I suspect, were more sensitive to environmental stimuli. So we're more aware of when weather systems are changing, and maybe it gave an evolutionary advantage. And if you go to medical conferences with lots of very bright people, you'll find very high incidences of migraine. It's interesting, isn't it? But everything comes with a downside. And the downside is when you get a balance problem, that alertness, that hypersensitivity to environmental pressure change, to weather, gets focused on your balance. And then the balance problem becomes much worse. So treating the migraine is really important. And I wonder whether the stress of lockdown and the consequences of lockdown will make many patients' migraine worse. I don't know. Maybe not having to go to work and see the boss is making people's migraines better. That's perfectly possible. I don't know. And there's no doubt that lots of my patients, when they retire, migraines get better and a lot of dizziness gets better. So there's a lot of factors at work here, aren't there? So diet change. I don't drink, so I can say this quite happily, but if you've taken to the red wine, very, very bad for you if you're getting migraine. So alcohol is not a good thing with migraine. Keep yourself really well hydrated. I saw Karen yesterday, and she has a 2.5 litre bottle of water. Quite how she fits that inside her, I don't know, but it's a really good indicator. That's how much water you really ought to be drinking, 1.5 litres maybe at least. Diet change, again, maybe some of us are trying to be healthier during the lockdown, but if you're nibbling at cheese and chocolate and so on, and maybe having Chinese and Indian takeaways because you can't go and buy things, these are all really bad migraine triggers. So really try and have a healthy diet. Do not skip meals. Exercise is a migraine trigger. And I have one lovely lady locally who every time she tries to go for a bike ride gets a terrible migraine. And there are lots of other triggers for migraine as well. But actually lack of exercise will decondition you. And deconditioning is a big thing in balance. And that can only make migraine worse. And even more so, altered sleep pattern. So I'm asking for trouble at the moment with what I've been doing in the last week or two. So going to bed later, sleeping during the day, not sleeping so well, are really dreadful for balance and so on. And something to address. And then finally, vitamin D. I've talked about vitamin D in the context of BPPV, the positional dizziness caused by crystals. But also don't forget that if you're self-isolating and you're not getting enough sun exposure, your vitamin D levels will start to fall. And if you have a dark skin, your vitamin D levels are likely to be even lower. So in our Asian population in Leicester particularly, we have really severe vitamin D deficiency, but we see it in a lot of people with fairer skins as well. And not only is that associated with BPPV, but it's associated with fatigue, general body aches and pains, and general imbalance. And vitamin D, as you may well know, is the sunshine vitamin. And there's a picture of it over here. That's the structure of vitamin D. You need 15 minutes of outside light exposure on your face and arms a day, on average, to maintain a reasonable vitamin D level. So many of us are managing to get our little bit of time in the sun, and that may be adequate for you. I don't think there's any great need to go and have your vitamin D measured, but I am a great believer on it. You know, we have a box at home, and as long as you haven't got other medical problems that might be a contraindication to it, I see only benefit and little harm from taking a tablet a day. And they're cheap as chips. You can just get them from the chemist or get someone to get them for you from the chemist. So that may be just a small helper as well. Okay, where are we going next? Well, this is me. This is where I'm going. This is when you hear on the news all about PPE. This is PPE, personal protective equipment. So I've got a hat on, I've got a visor on, I've got an FFP3 mask, which is jolly sore, I can tell you. When I take that off, I've got bruising and indentations all over my face. They're really sore to wear. This is a plastic apron, which we have to wear, and these are gloves. And you've heard on the news about how expensive it is. Goodness me. These are cheaper than bin liners to make. You know, you go and buy a roll of 50 bin liners, and they cost, I don't know, £5 down at the supermarket. Those bin liners are much thicker and much more expensive to make than these. We've just bought a roll of 100 for the London Road Clinic. And I thought, well, there'll be 2 or 3 pence each, maybe £2 or £3 normally for a roll of 100. Maybe in the lockdown, there might be £5 or £10. Do you know the cheapest we've found and what we've got to pay? £295 for a roll. This is what we're facing at the moment. And, you know, we have to have it if we're going to reopen. And this is what we're facing. This is what the NHS is facing. And goodness, I would not want to be a politician at the moment, I tell you. You know, it's just impossible getting this stuff in. So we have to wear one of these for every patient. The masks are £10 or £20 each. If you try and, well, you can't get them online for love nor money, but we've managed to source a few. The visors, our local school, the Leicester Grammar School, is making them as well for free. Fantastic. So there's been real help, and we double glove as well. And gloves, we've bought a lot of gloves. They're about 5 times the normal price we pay. I mean, it's extraordinary, but we have to do this. Now, things are changing. As I said at the beginning of this session, we've really not been seeing people. We've not been doing very much at all because everyone's been very, very afraid. And as you may know, we had an ENT consultant who works just outside the county who died in our hospitals in Leicester at the beginning of the outbreak. One of my colleagues here, a very lovely chap, was really ill over the last few weeks, but's okay now. Most of us, to our delight and amazement, have actually got through this without any problems. All of our admin staff, and we're really proud of everyone. I mean, seriously proud of everyone at every level of how they've supported us and how cheerfully they've supported us and how they've come into work to help. So we want to get back on our feet. Now, NHEI is National Health Service England and National Health Service Innovation. And these big organisations, national bodies, give advice on what we can do and what we can't do. And when we started out in mid-March, they put out a thing, stop. All outpatient work had to stop. All testing had to stop. So that's why the London Road Clinic closed towards the end of March. And that's why all of our NHS practices closed towards the end of March. Now, at the beginning of April, they updated it to partial stop. In other words, we could do things in an emergency like hearing tests and so on where we needed to. But as a general rule, we weren't allowed to do anything at all. Now, I've been asked, because one of my hats is president of the British Society of Otology, which is the ear surgeons group. And we are part of an organisation called ENT UK. And the leader of ENT UK, a chap called Nermal, has been astonishing. I'm just in awe of what he's achieved. I'm so proud of what he's achieved on our behalf as well. And I think ENT in the UK has really been one of the great leaders and innovators on putting out policy and guidelines and getting us back to work. Now, this has been a huge amount of work. It's a big document. I finished it, as I say, at 2 o'clock this morning. So I was very, very happy to get that submitted. And I've been working with a very large number of organisations throughout the UK and abroad, because I want to get consensus across all different organisations. I don't want to just give our guidelines. I want something that works for everybody. And I have to say, to my amazement, the government have engaged with us as well. I mean, we're only ENT surgeons. There's only 600 of us in the UK. And I wasn't expecting any way at all to get in touch with the government, which is sad. You may have seen Chris Whitty, the Chief Medical Officer, on TV. Does that a name that rings a bell with you? Well, Chris was a really good friend of mine. We were in medical school together at Oxford. and we were there were friendship circles, and he was certainly in our group. Now, I haven't seen Chris for many years, and I'm not in touch with him, but I'm so desperate to be. I just want to sort of almost hug him and say, I'm so proud of what you're doing. And he has just been a real beacon for us all during this. Now, clearly, I am only an ENT surgeon and not important enough to be in touch with the Chief Medical Officer at the moment. But to my delight, NHS England have engaged. So I've been corresponding with them and helping them as best I can with the preparation of new guidelines. And they'll be published, I think, next week. And whilst I don't want to preempt that, it looks like where we're going is to prepare for a return to work. Now, that's what you want to hear. And if that's the only thing from today, that's what you want to hear. And what it means is that we can start engaging with you, and where necessary, testing you, and where necessary, seeing you again in the coming weeks. Now, the British Society of Otology, whose guidelines I've written with 3 other colleagues, and a whole raft of other people, are saying that it is now safe, we believe, to return to doing balanced testing, to return to seeing our patients face to face on a selected basis, and to starting treatments again. What we're recommending is that in most cases, if not all cases, we should do a telephone consultation first. Now, the reason is this several-fold. Firstly, we'll spend a long time with you on the phone, and we can get all the information down we need. So we can be clear, maybe we can do an Epley manoeuvre over the phone and you don't need to come into hospital, and that will be great. Maybe you need balance tests and a scan. Well, we can arrange those, and then when you come in to see us, you don't have to spend so long in clinic with us. So there's less face-to-face contact, and that's what we want, isn't it? We want to minimize the contact time. And we can set up, as I say, set up balance testing, set up physiotherapy. And we'll also be allowed to see you definitely to do intratympanic injections. So if you've got Meniere's disease, we can do steroid injections, and we can do gentamicin injections if we need to do that as well. We can see you to do Epley maneuvers, and we can even see you to do microsuctions of the ear. So if your ears are blocked with wax or your ears become infected, this has all been stopped up to now, but we're going to return to be able to do that, which is really, really great news. Now, this is me again. This last one I showed you. This is called an FFP3 mask, and this filters out, I think it's 99.7% of particles. Is jolly sore. This is a respirator, and you can see on here, this is my respirator. We each have our own individual ones. We've got plenty of PPE, but you have a tight seal around the edge. Then you have a very tight seal in here. Can you see the second internal mask? So visor, mask, and then we have air filters on the side. So if you put your hands on the air filter, I can't breathe. And if I'm going into theatre, say, to do a tracheostomy, open up the neck of someone who's got coronavirus, this is the sort of thing we'll wear. But they're heavy, they're really uncomfortable, they're really hot. And we've discovered that you often begin to build up CO2. So you're rebreathing your own air to some extent. And my colleagues have done longer operations with them on, have begun to sort of lose concentration and so on. So these are all difficult things to wear. And of course, I can't do ear surgery in this because this is a rock hard glass visor or perspex visor, and I can't get close enough to the microscope. So we're having to use different techniques. However, and I'm not going to wear that if I see you in clinic, don't worry, it terrify the children. Certainly, everyone will be out of the clinic before you can imagine. But what we are going to be able to do on the NHS is we are going to be able to see people. So what I'm doing is we're doing telephone triage, which means selection, then telephone consultations, and then we're going to select from that group those who need testing, and then get back into clinic those who we need to see, because I need to exclude, if I haven't seen you before particularly, I need to exclude neurological problems and problems of the ear and so on. And that's all going to start in the next few weeks. And we're clearly going to be very cautious if you're in a high-risk group. And if you're in a high-risk group, you know you are. And we'll try and do as much as we humanly can by telephone. It's a balance. There's no right answer. We'll do our very best there. But I think it's going to be a long time before we get back to normal. And then down at the London Borough Clinic, where some of you have been, this is Karen, who you just saw wearing I'll see if I can find Karen on my screen, wearing a cake on her, there she is, hi Karen, wearing a cake on her head a minute ago, who's been wonderful. And we've bought absolutely masses of PPE from everywhere that we can. And we're hoping to open in a couple of weeks' time. It's not, we have to get government approval and get everything done, but we're desperate to get back to seeing our patients, because I know some of you really, really want to be seen. But what I'll try and do, if you want to come back, is do a telephone consultation first, and then we'll get everything prepared for you. And we'll get up on the website all the rules and regulations. So we're only going to have 1 or 2 people in clinic at any one time. We're not going to have a busy clinic. We'll probably get you to wait in the car outside so you're not in. Most of the chairs have been taken out of the reception room. We've got whole processes and flows in place. We're going to have a big Perspex screen. You'll see that at the NHS as well. So all our staff are protected. And this is lovely Meniere, who some of you may know. And Meniere does the microsuction of ears. So if you've got blocked ears, Meniere is a sister at the infirmary as well. And at weekends comes over and helps clear people's ears. So we've got Meniere, and she's very, very hot on the exact specifications that the government require. And so we're drawing up all of those guidelines. And it's going to be different to how it was before. It's going to be very strict, but we think that's clearly best for you and best for everyone. So we are beginning to get there. And I'll just say, I'll wrap up there and say thank you to Kevin and the whole team for joining us today and for helping set this up. And I hope that's been of some help and given you some insight and to know where we are, and that we are making progress. We are going to get through this, and we have real plans for making things better. There are ways we can help now, and there are definitely going to be loosenings and ways we can help in the coming weeks. So I hope that's helpful. And if you've got any questions, I'm very happy to answer if I can.
Brilliant. Thanks, Peter. Yeah, very good. Very informative. We can't hear you clapping, everyone, because you're muted.
No, you don't need to.
Wave your hands.
You can do that, yeah.
Brilliant, Pete. That was really good. Thanks again for all you're doing for our balance community and everyone, because it's obviously these days really at personal risk. So it's much appreciated, everything you're doing. Brilliant update and wonderful advice on how we can probably help ourselves while we're stuck in lockdown. So it's been fantastic for today. Rupal, you're now going to run our question and answer session. So over to you.
Yeah.
Rupal, can I just say, sorry, before you say something, I get quite emotional seeing you all. I've just gone through the screen to see who's watching me. It's so lovely to see you. Thank you for joining. Oh, I have tears in my eyes now.
I'll tell you what, I mean, it's just given us, I think, a little bit of an insight of what it's like working on the front line of what, you know, is a strange time for a lot of people, can be quite scary for a lot of people. I'm hoping that people have got lots of questions. I know I've written a few things down that I certainly want to ask about, and I'll kick off if that's okay. And if people do have a question, please either put your hand up or stick your name in the chat box, and then we can go through some of these questions. I just want to talk to you a little bit about, Peter, if you can just sort of describe, you talked about people recovering, which is fantastic news, because I don't think we actually hear enough of that as far as COVID is concerned. Can you give us a bit more of a picture of what that's like?
Well, from a coronavirus perspective, or a dizziness perspective?
From a coronavirus perspective.
Well, I mean, thankfully, I'm not exposed to it too much. I mean, we have quite a lot of people on the wards, but what you've got to remember is it's a very, very select group. And you'll have read as much as I have, but we think that, you know, there will be probably several million people in the UK who have already had it. Many people won't know they've had it. We think that about 0.775% of the population are going to die of it if they get it. But it's going to be the great majority of people who are getting into trouble are in care homes or very elderly. And most younger patients are not having that experience. And we've had quite a lot of doctors get it around the country, and some seriously. Now, the people who are getting very seriously ill, as a rule, are those who are very elderly, often with lots of other medical problems, or those who have a very big exposure. Now, this is probably why our ENT colleague died. I have no more insight than anyone else. But as an ENT surgeon, quite a lot of what we're doing is looking down people's airways. So we put cameras down people's throats, and sometimes during anesthesia, patients actually breathe in and out through this. So they spontaneously ventilate, and their breath comes out through this, this tube, and it blows into our face. So 3 months ago, we had no idea that this was dangerous. No one knew that this was a problem. And we're probably, or we get a big viral load coughed onto us. One of my colleagues who got sick, although he was wearing all the masks and everything, had a patient whose Pax he was taking out the nose, and the patient coughed, a lovely, lovely person. The patient coughed over him and probably gave him a massive, massive exposure to virus. And you may have read of this term of total viral load. And this is an important concept. So I suspect all of us have breathed in coronavirus. I suspect if you've been out to Tesco's, you'll have breathed in coronavirus. But there are cells in your immune system which can gobble them up, and that's not too much of a problem. But if you get a massive dose of coronavirus coming in, it overwhelms your immune system, and then you become very seriously ill. Most people are getting it. I mean, all of them, the doctors I've spoken to have got it. It's a really unpleasant experience. I mean, they're really pretty poorly. My senior fellow, who wonderful, wonderful friend and colleague, he couldn't, and we speak the whole time, he couldn't speak to me on the phone for 4 days. He couldn't breathe well enough. So this is a frightening condition if you get it, and it's not one to be taken lightly at all.
Certainly good news that, you know, there are people recovering and coming out the other end.
The big but, yeah, is the vast majority of people either don't know they've had it or they're recovering and making a full recovery. Vast majority of people. You've got to remember that I think, did I see that the mortality rate is about 7 times as high as for the flu, for seasonal flu. Now you need to put that in perspective. So the risk we're under this year is the aggregate risk of the last 7 years of flu. Now, none of us worried about the last 7 years of flu, did we? So there are lots of different perspectives. And I don't want to underplay this because it's a nasty illness, but I don't want people being too scared about it, because you're going to ultimately, I think, put yourself at more harm if you completely lock yourself down and don't go out and get some exercise over time, because, you know, we're all humans, we need to interact and we need to exercise.
Should we go to Caroline? Because I know Caroline Evans, you've got a question, so please ask it yourself. I'd rather you ask the question yourself. Caroline, if you just unmute.
Sorry, I was muted. Yeah, so I had some balance testing at the Royal towards the beginning of March.
Right.
And I was expecting some results towards the end of March, but obviously with the whole situation, I understand that that's not happened. But I just wanted to check, with it being a while ago now, when everything gets back up and running, will I still be able to get those results, or do I need to be tested again?
No. You must have been just about the last person to be tested, Caroline.
Probably.
So well done. So there are 2 things that will happen. What I do is traditionally, if you're under my care, all of the balance test results get given to me, and then I write you a letter and your GP a letter with the results and with a management plan. Now, the thing is, because you were tested at the end of March, it's just when everything started, you know, coming down. And so there were some difficulties. But what I'm doing is I will give everyone a phone call at home with their results. So you'll be on my list to phone at home, and I'm phoning lots and lots of people. There are issues again in that we have what we call a shadow on-call rota. So we know that colleagues can go off sick. One of our colleagues is unable to come in because of risk factors. So, for example, next week I'm covering him for 2 days and nights on call. Last week I covered him for 1 night and day on call. And when I'm on call, I have to cancel the balance clinic because I have to do emergency work. So it's not as efficient and predictable as it used to be. But the guidelines that I've written for British Society of Otology, the national guidelines, are very clear that everyone's notes must be reviewed and everyone must be written to or phoned with their results and seen as soon as we can. And if your problem is a chronic unsteadiness, Caroline, what the plan will be is that I may write to you initially with the results. More likely, I'll phone you at home with the results. And then if you need vestibular physiotherapy, I'll get Michaela or Andrew or one of our physiotherapists to contact you at home and start your treatment on the phone as well.
Great. I've already started to have the physio over the phone with Michaela, so that's fantastic.
Great.
So that's working really well.
Yep.
Brilliant.
We'll be in touch.
Thank you.
Thanks, Caroline. Can we go to Nicola? Nicola has got a question. Hi, Nicola.
Hello.
Hi, Nicola. I can hear you. Yep.
Hi, Peter. I was treated and diagnosed by yourself on 2017 with triple PD, and obviously live with all the dizziness still and all the balance condition. And I found it really hard as well working from work, because I'm having to work from work. I work with NHS and that was social care, so my work's, I've had to adapt with the needs of the service, and I've spent quite a bit of time on the laptop, and which is obviously, I've noticed a big increase in my dizziness. So I don't know, what I could be doing to help settle that down a little bit more, because I think with added anxiety on top and stress and work.
Yeah. So you're presenting really exactly the scenario that we've been worrying about. So being on Zoom, I'm having up to sort of 3 meetings a day on Zoom. Is actually quite hard work, and I'm very fortunate that I don't work on a computer usually, and I work face to face. But those of you who have PPPD or vestibulopathy know that computer work where things are moving around is actually very difficult, and if you've got migraine, the same is true. So the things we need to do is try and limit your time, try and have the brightness of the screen turned down a little bit, don't have the screen too bright. Try and avoid coffee, tea, caffeine, keep yourself well hydrated, have a healthy diet, try not to snack too much, have regular food. But I think the key thing is to have regular breaks and to try and exercise. So I don't know if you have a garden or you're able to get outside, but I really genuinely think the key is trying to get outside for your own sort of mental health and well-being, as well as your physical health, the same for all of us, and getting some sun, getting some exercise. Keeping your vitamin D levels up, doing your vestibular physiotherapy as best as you can. If you're, I don't want to talk in front of everyone about your individual issues, and of course I can't remember your individual issue anyway, so I'm not going to break any confidentiality. But if you're taking an SSRI, citalopram, sertraline, or venlafaxine, you might consider increasing the dose of that. If you're not taking it, absolutely, I would speak to your GP about having it prescribed. But if you're going to start it and you're not taking it, start it in a very low dose. So it should be the very, very lowest dose that's available, and increase it very, very slowly. And then finally, there's a CBT, that's challenging, but I would suspect there are ways of accessing that remotely through your GP. I suspect it's not ideal, but if you're struggling, you are absolutely not alone. And I suspect the majority of us in the forum today have been having some difficulties. And I'm very fortunate because my life hasn't changed very much, because I'm out every day at work, I'm meeting my colleagues. So for me, hasn't been a difficult thing to do. But for most people who have been at home, I think it's been very challenging. And you need to get each of those strategies addressed. That's quite a long list of things for you.
Yeah.
Is that helpful?
Yeah. And also, sorry to keep you, but you mentioned about a study taking place on triple PD.
Yeah.
How can I put myself forward?
Thank you.
I would love to be involved.
Well, really appreciate that. So what we're going to do is we are going to look through our records for people who've been diagnosed with triple PD and choose a selection of those and invite them to be part of it. It'll be it's been run from the University of Leicester, so just a short walk from the infirmary, but we may well see people at the balance centre in the infirmary as well for some of their testing. And we're just incredibly excited by this. And it's not unpleasant at all, any of the tests we're doing, but they're really, really clever. I mean, wow, working with scientists is a really exciting thing. We've got lots of big brains on it. We've got lots of ideas. So thank you for that. We have got ethical, obviously we've got the funding, which is extraordinary. I mean, to get that sort of funding is almost unheard of internationally. So we feel very honoured and privileged to have got that. We've also got all the ethics in place. And what we're doing at the moment is we're writing up the protocols for the studies. So we may launch some advertising as well regarding that. Yeah, so we're not.
And you'll appear on BBC Radio Leicester, of course, with me, without a doubt.
Oh, well, that's a really good idea.
Very exciting news.
Yeah, that's an excellent idea.
I think that's a brilliant idea.
Flip over so I can see you. Okay, there you are. Hello.
Nicola, thank you. I hope that helps. Annabelle, I know you've written your question out, but would you like to ask your question yourself directly to Peter, Annabelle?
I'll try. Can you hear me? Because
yeah,
oh, good.
Loud and clear.
Excellent. Yes, Professor Rea diagnosed me with PPPD, and it's been fabulous. I went on to assess SRI, and I've been a lot better. But I have read that one of the reasons why some people don't handle COVID-19 very well is because their metabolism is quite low, and I've actually tried to halve my tablets because I'm concerned that I'm putting on weight and I feel sluggish, and I think that is probably because of the SSRI. So it's a balance, isn't it, between
I'd be, I mean, the normal caveats, be very careful what you read. There is a huge amount of stuff totally non-evidence-based going out there, number one. Secondly, there's a lot of evidence that people in the lockdown are suffering fatigue. It's a psychological consequence of the lockdown. It's an enormously stressful period. Very, very few of us have experienced this before in our lives. One of the consequences has been fatigue. Fatigue has also been associated with the post-viral phase and indeed the viral phase of COVID-19 infection, although I think that's an intense fatigue, so intense you can't get out of bed. Metabolism, it's a bit of a vague term. I have absolutely no evidence at all that the metabolism of medication has been changed because of coronavirus infection.
Okay.
I very, very much doubt that.
I might have to put my tablets back up again so I feel better.
Annabelle, what I would say is what works for you, do.
Okay.
Because one of the things about these medicines is you can titrate them, you can adjust them within sense yourself.
Yes.
And if you're finding you're getting very sleepy on them, and of course some of them can cause fatigue, you're absolutely wise, just reduce it. Be more careful increasing it, but there's no reason for you not to reduce it. And it may be that your circumstances are different, so you're not as active and stimulated maybe in lockdown as you were with whatever you did before.
Yes, I have been completely on my own for quite a long time.
How long have you been on the SSRI?
Well, on the SSRI I went in November.
Okay.
And I was taking paroxetine, so I went back on to paroxetine.
Yeah.
But I have been in for 2 weeks longer than most people.
Yeah.
Okay. And yes,
I mean, we normally suggest a 12-month course of medication, gradually sloping upwards and then gradually sloping down. And if you're okay on a lower dose, stick with it, because some of the SSRIs and venlafaxine can be a challenge to come off. So the lower the dose you're on.
I'm actually been feeling dizzy again, so that's why I'm thinking it's a difficult balance between.
Yes, I mean,
putting on weight and actually I'm going to have to get more fit. That's no doubt.
I think that may be the case. Getting fit was a good thing. But you're very early in the SSRI treatment, so I would probably maintain the higher dose if you can tolerate it at the moment. I'm not sure about.
All right, Annabelle, thank you. I hope that helps, and Peter, thank you as well.
Very much.
I'm aware that there are people on the phones as well that can't type in messages or can't tell us if they want to ask any questions. So please, this is your opportunity now. I think hopefully Kevin will unmute you if you've not unmuted yourself. So if there is anyone on the phones that's got a question for Peter, then please speak up now.
Just a huge thank you.
Who's that?
For letting us, it's Wendy.
Wendy, okay.
Just a huge thank you for giving us some more information, because it really helps.
Good. Thank you.
Yeah, no, I would. I
Thank
think
you.
all of us will agree to that. A couple of more questions from me, and if anyone's got any more questions or if they think of anything, either put your hand up or again just put your name in the chat box. You talked about, Peter, you know, encouraging people to get out, and I think at the last meeting a lot of us said, actually, do you know what, it's really nice because it's a lot quieter, and for people with a balanced condition, we're not having to juggle lots of distractions like traffic, noise, you know, going to the supermarket where there's lots and lots of people. So in that sense, I think for quite a lot of us, I wouldn't say everybody, but quite a lot of us, it's actually been a positive experience because there's not many people out on the roads. But what advice can you give to people who, I mean, my brother's on the chat for the first time as well. He is, he is like others, self-shielding, so they're not meant to be going out. Yeah. What do you do in that situation? What advice are you giving people there for balance?
My brother-in-law and family live in Rome, and they live in a flat on the 5th or 6th floor in Rome with a small balcony. And they have a beautiful daughter who's in her mid-20s, who I think is being chased by every hot-blooded young man in Rome, if I can, it seems to me. And she's out at a party every night. I mean, if I go out for a party, it takes me a month to recover these days, but she seems to be out at a party every night. For the last 2.5 months, she's not left the house. Because in Rome, you're only allowed out within a few yards of your house to a local shop to get food or drugs and nothing else. And you will be stopped by the police if you go out with someone else as a pair and get fined. And it's, you know, for someone who has been out partying every night, she has just hit a brick wall. And it's been a real challenge, you know, for her. And they're delighted they can actually, there's a picture of her out by the Colosseum she sent on WhatsApp yesterday. And this is the interesting thing. The lockdown's been lifted in Italy, but they're all still staying inside because they're too scared to go out. And she had a picture of her looking at the Colosseum on her own. No one else out at all, even though they're allowed out now. So this has had a huge impact on people. And I don't know the right answer, Rupal. I mean, I think that clearly, if you're in the house and self-isolating completely, you need to be on vitamin D. I mean, I think that's one thing. If you have a balcony or a small garden, I mean, you need to do a Captain Tom, don't you? You really need to get out there and walk around the garden. If you're in a flat and shielding, I don't know the right answer because I think you're in a terribly difficult position. But I suppose that the ways of looking at it are, what you mustn't be doing is taking to your settee and sitting there all day and then going to bed, because that's a catastrophe. You know, whatever you do, you have to be pacing the floor, getting some exercise, whether you're allowed out into a communal garden or just walking up and down the street when there's no one else around. I mean, my parents are well into their 80s. My in-laws are in their 90s in the village here. And, you know, speaking to them through the window is like speaking to them in prison. It's heartbreaking. But they still go out when they know no one else is around. Yeah.
So it's trying to keep active in whatever way.
So important to keep active and to keep feeding yourself well and to keep in touch with people. Because this is wonderful. I feel like I'm with you all at the moment.
Sandra's got a question. Sandra, do you want to ask your questions to Peter directly?
Do you want to unmute yourself? Just at the bottom of your screen, bottom left. That's, and again.
On again.
Yeah, you got it.
Yeah.
Well done.
Yeah. Thank you so much. I'm not a patient of yours. I'm in London, but I do see Louisa Murden.
Louisa, she's a lovely, lovely lady. She's a very good friend.
Right. I did ask her to refer me to.
Don't say anything. I know you won't say anything bad about her.
I won't. It's just difficult to see her. I see her through the NHS.
Yes.
And having joined this group, I did actually ask her to be referred to you, but apparently that can't be done.
I'm not allowed to accept people on the NHS outside the county. We're just utterly, utterly overwhelmed.
Yes, I understand. I'm really interested in what you said about the research, and that you talked about PPPD and vestibular migraine, and I have been diagnosed with vestibular migraine. I don't have the vertigo sort of spinning. It's more this walking on marshmallows and so on. I was on venlafaxine for a while and was quite good on that. Dreadful time coming off it, I have to say. Highly warned. And I think I've tried about 6 or 7 different drugs. I see Dr. Lambrew as well, but I don't have headaches much.
No.
She's at St. Thomas's. I've just been put on to Loxetine, and I'm having a bit of luck with that.
Good.
I think it's another.
It's an SSRI.
Yeah. Is that a bit like venlafaxine?
No. Yes and no. There's 2 broad groups. There's the SNRIs, which is venlafaxine, and then there's all of the others, which is the SSRIs. So fluoxetine, sertraline, citalopram, they're all SSRIs. So they're a bit different to venlafaxine.
All right.
Where the research is at the moment is that we know that with the combination of treatments I've discussed, including an SSRI of venlafaxine, about 80% of our patients will get better with PPPD. So that's the great news. What we don't know at the moment, we don't have the evidence to say for Mr. A and Mrs. B, with your profile, this drug will be better. We don't know that. So that's one of the things I want to get into our study, that we were talking about the research that we're going to be starting in Leicester, because we'd like to be able to identify subgroups, substratify, to try and work out which person will be best on which particular drug. But at the moment, as it's a really helpful comment you've made, Sandra, because for everybody, that if you don't succeed with one of the venlafaxine or SSRI groups to start with, it's absolutely worth trying another one. Now, I would also make the comment that they, from my perspective as an ear surgeon, a balance doctor, are more applicable for PPPD than vestibular migraine, but we know that the SSRIs can be very helpful for vestibular migraine as well, which is interesting, isn't it? But there are lots of other elements to vestibular migraine management which are really important. And we often use treatments that we use in general migraine or vestibular migraine because there's been less work done on this. Now, just as a sort of general point for everybody, one of the things I feel very strongly about is diet. And, you know, if you look at, if you come to see me, I will be not drinking a cup of coffee. I will have decaf tea. Michaela is smiling over there. She taught me all of this many years ago when I was getting really bad headaches. Thank you, Michaela. But caffeine is the really big trigger. I see Kevin having a slurp as well. But caffeine is one of the really big triggers. So I feel much more strongly about diet than my neurology colleagues. And Louisa is an audiovestibular physician. So caffeine, chocolate, cheese, Chinese food, citrus fruits, and so on. Keeping well hydrated, having a regular sleep pattern. Don't sleep during the day, go to bed and get up at the same time. Don't skip meals, have exercise, keep yourself healthy. If there are stresses in your life, try and address those. These are all really important elements to migraine management. And with that, you may not even need medication to manage your migraine. The majority of people we can get by. But of course, migraine can be absolutely horrific. You know, it can be horrible. And there's a massive spectrum of it.
Is there a distinct difference between PPPD and vestibular migraine?
Oh, absolutely. Yeah, there's a huge. Yeah, they're completely different conditions.
But the research is going to cover vestibular migraine as well? Yeah,
for sure. The main bulk of the funding is for vestibular migraine. Okay. Yeah, and Louise is a great name in that. You know, she wrote Cochrane Review on vestibular migraine, but we're very fortunate that we've got some huge funding for it.
That research is likely to start?
Well, the funding is in place, the ethics are in place, the project protocols are written up. So as soon as we're allowed to start seeing people, we'll start recruiting. We got stopped because of lockdown. We can't justify running this type of research when that we can't do testing and there's lockdown. But one assumes it will be in the next couple of months.
Right. Sandra, I hope that answers some of your questions. I know that lots of people have got lots of questions probably and don't necessarily want to, ask them in this forum, which is totally fair enough. There was a couple of things I just wanted to mention, Peter. You talked about doing sort of virtual, treatment for people, and it seems to be working quite well. I just want to remind people as well that Michaela has made some lovely videos online have you not, Michaela, that people can also access. She's not going to talk.
Oh, there we are.
She can't unmute herself, but Peter's.
So there you go.
Oh, hang on.
We can hear you.
It doesn't work on this. Hang on. Oh, there's Michaela.
If you have a look on YouTube and Google my name, so it's on the screen there, and there's a video for the vestibular ocular reflex exercise, so that first exercise for imbalance treatment. There's the Brandt Daroff exercises demonstration, and also there is a demonstration of the Epley manoeuvre, and I talk through how that's done. And so hopefully that's going to be helpful for a lot of people. But it's all there. I think I've sent the links to Kevin as well for the website and for the Facebook and everything. So hopefully all those are there for you.
And those will be going up, very soon if they're not already up. Kelly is also, don't forget, looking for, you to participate in creating a bit of a diary during lockdown and what it's like having a balanced condition. So please do get in touch with us for that. One final call then for anybody else that's might have any last questions for Peter. I think Kim's got a quick question.
Kim, go ahead.
Kim, go ahead.
Hi.
Okay.
Right, I'm on beta histine for Menieres, and every time I try to reduce it, I get real bad pressure in my head. Is there anything I can do about that?
Yeah, it's an interesting question. If you look at beta histine, circ, is what we've used for millennia for managing Meniere's disease. There was a publication in January 2016 in the BMJ with a really big study which questioned how effective it was. It was not felt to be much more effective than placebo. Now, again, we come back to this sort of stratification that there do seem to be a number of our patients who absolutely swear by beta histine and get into real trouble when they come off it. And we don't really understand why some people are in that group and other people it's not very effective for. Now, we have to accept that there is a placebo effect with beta histine. Nicola, that's very sweet. Sorry. I just had my son walk past without anything on, so I'm glad he didn't come in. Sorry, Kim. So with beta histine, the problem is that we don't know what element is related to the drug and what element is related to placebo. Now, I know the pressure feels very real to you, and it may be that you are someone who is very sensitive to beta histine and who it's a balanced sedative for, so it really, really helps you. Or it may be that the placebo effect, your sort of subconscious is saying, yikes, I've not got treatment, and then it's causing muscle tension headaches. So how long have you been on the beta histine for?
Oh, years. I'm on 32 milligrams.
Well, after high dose. So what
three times a day.
Okay. So what I suggest you do is go down to 16 plus 32 plus 32, then 16 plus 16 plus 32, then 16, 16, 16, then 8, 16, 16. And then you can go down to 8 3 times a day, 8 twice a day, and then 8 once a day and stop it. And, if you've been on it for years, and you're not having attacks at the moment, I think you ought to come off it. It's a perfectly safe medicine. We've hardly had any problems with it, but it's much better to be off it. And if you do have relapses with vertigo rather than tension headache, then there are other treatments with the interesting panic therapies. The one other thing just to mention, just for everyone, is the commonest cause of tension headache is paracetamol and brufen. So if you have daily headaches, the commonest cause is taking paracetamol or brufen regularly. So you need to go, if you take them for more than 5 days, they cause headaches. It's called analgesia headache. So try and wean yourself off and kind of cold turkey, as it were.
Brilliant. Peter.
It's more like a pressure in my head than a headache.
Yeah, so you may find that that's part of the placebo effect. Not sure, can't tell you for certain, but that's a definite possibility. Yeah.
Thanks, Kim. Thanks for your questions, Kim.
Peter, just one quick one. We're getting a few new people joining us who are at the beginning of their balance journey. A question at the moment: do you know if the referral system is working as normal?
Oh, yes.
People be referred.
I read every single letter that comes in. It nearly kills me. I have piles and piles and piles. So I go through every letter that comes in to me. I mean, I have colleagues who may see them, but I read every letter that comes in to me and I triage them in times of urgency, whether I'm going to do an urgent phone call, a routine phone call, or a clinic appointment. And I've looked at every single set of notes, or I will look at every single set of notes for people on my waiting list. I mean, I can't see all thousands at once, but every week in advance, I look at everyone I'm due to see, and I go through every set of notes and decide, am I going to phone you? Am I going to see you in person? Am I going to put you back to when I can see you in person? So everything is carrying on as normal, and we encourage you to keep getting in touch.
Peter, what advice would you give to people? Obviously, you know, this is going to put things back for people suffering with a balance condition, and the anxiety and then the stress of that will you know, probably not help. But what can you say to reassure people that they will be treated, and if they need the help, they will get that help?
Oh, absolutely, it's there. I mean, I think I'd also say, Rupal, that referrals have gone down dramatically. So it's actually not as bad as you might think. You know, we've only been shut down for 7 weeks. So it'll be a couple of months or so of shutdown. A lot of people I've helped on the phone already anyway with Epley manoeuvres and so on. So I've triaged those over. And I mean, as the government is saying, you absolutely must get in touch. You know, we're working flat out, and don't think that we're too busy to see you, because we're not. We're quieter than we usually are. Is that simply because people are, you know, don't want to bother, you know, the NHS at the moment? I don't know. You tell me. But I think that's part of it. But I think also because people at home, they have less stress, because they've not necessarily got the work stress in some cases. People are picking up less infections, so they're getting less vestibular neuronitis. People are going on less holidays, so they're getting less pressure-induced dizziness and so on. And there's a whole, and absolutely people don't want to trouble doctors. I'm sure, I've got no evidence for that, but I'm sure that's the case. But we want to be troubled. That's what we're here for. And what we're most nervous about is there's a whole cohort of people who haven't got in touch, who will go and have dizzy spells, fall over, fracture hips, and get into real trouble. And this is what I've said to NHS England, and they've accepted. I mean, I think they've been absolutely brilliant, I should add. They've been really receptive, and I wasn't expecting it. And I can't predict exactly what they're going to conclude on their Monday meeting, but they've listened to me, they've sought my advice, and I've given them my advice. And the bottom line is we need to reopen, because people are going to get into difficulties if we leave it too long. And I'm pretty sure, well, you can see as well as me, that's what the government is saying almost every evening at the moment, and they're right to say it. Yeah, Peter, you know, I think on behalf of all of us, if there are no more questions, we'd like to say a massive thank you for taking this time out today and, you know, reassuring us really. Thanks, Anne. Look, we can do a little all right, have a really good weekend. I look forward to seeing as many of you as I can in July. Oh, I think we've got one question. Someone's... Can we do one final question? Go for it. No, you're blocking something with your finger. Hello. 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 You're on.
Hello. Yeah. You diagnosed me with Menieres and vestibular migraine, and I'm waiting to have more balance tests and a scan. Yep. But the only thing is, at the moment, the doctor is giving me some tablets for another condition, which is trapped nerves. So I'm on antriptyline, and the side effects of them cause vertigo. So I'm worried that about taking these tablets, and I'm worried that I won't be able to have the balance test because of the antriptyline. Okay, so good question. So if you read any tablet side effect, dizziness will almost certainly be on there as a potential cause. Amitriptyline is my favourite medication for migraine and vestibular migraine. So you start at 10 milligrams. Take it in the evening and take it 12 hours before you get up in the morning. So if you get up at 7 in the morning, take it at 7 in the evening. Try not to have too much alcohol with it. And then you gradually build it up. So you can go up to 20 milligrams in month 2, 30 milligrams in month 3, up to a maximum of 60 milligrams at month 6 if you tolerate it. Some people find it makes them a little bit woozy, but generally people tolerate it pretty well. It's a good treatment for vestibular migraine. It will not stop you having your balance test when we reopen. Right, okay then, thanks for that. And it won't cause Meniere's attacks or anything? Won't be a trigger for that? Sorry, my son has just walked past again with that.
Anyway, no, quite the reverse, because Meniere's and migraine play off against each other. So if your migraine's bad, your Meniere's will get bad as well. So if we can suppress your migraine with the amitriptyline and all the dietary and lifestyle advice that we've discussed this morning, then that will reduce the likelihood of you having Meniere's attacks. So no, good choice.
All right, thank you.
Thanks very much.
Thank you.
I look forward to seeing you. Okay.
I'm guessing you need to go and get some rest if you can. Thank you again, I think.
Lovely to see you all. All right.
Really appreciate it. Thank you very, very much indeed.